You can start, Dr. Greenfield.
Hi, good afternoon, everybody. Welcome to House Calls. This is the second in our series of free webinars hosted by the Joint Pediatric Neurosurgery team at Weill Cornell in Columbia. And it's my pleasure to be your host for the second in this series. My name is Jeff Greenfield. I'm a pediatric neurosurgeon at Weill Cornell in Columbia. And I'm really fortunate to have with me today one of my great partners from the Department of Physiatry and Rehabilitation Medicine, Dara Jones, who is going to be co-hosting this interactive webinar on the very, very specific but important topic of spasticity, specifically what causes it in children, how to manage it, and some of the options that we have both medically and surgically. And that's how we're going to sort of divide our talk this afternoon so that we can give better and sometimes lifelong improvement to some of these symptoms that affect so many children and adults with spasticity, many from cerebral palsy, but from many other etiologies as well. You can see Dr. Jones, she'll introduce herself when she begins her portion of the segment. And I'd like to give a thanks to Roseanne and Tatiana and Sue, all the people that have put this seminar series together. There will be an active chat box that you certainly should feel free to use during the talk. If we can answer it during the talk and it's a quick question, we may share it at the end if we feel that it may be relevant for the larger audience. So thanks for adding those questions in there. And hopefully you enjoy this afternoon's presentation. So I've already introduced myself and Dr. Jones there. Instead of wasting time on that, I'll move forward here. I wanted just to put this slide at the beginning here. This is the team that you may encounter one or many pieces of if you're a parent or a young adult who has spasticity and you're trying to find a therapeutic route to improve your symptoms. As a neurosurgeon, I put myself way at the bottom here at this list here, you can see in red, because there's so many other pieces to the puzzle of the complex care of a child or adult with cerebral palsy and spasticity. Often it begins with the neurologist or physical therapist. Many of you will first get diagnosed through the pediatrician's office, which isn't even on here. But then between the physiatrists, orthopedic surgeons, so many people in labs, orthotic clinics, social workers, nutritionists, there's a lot of people who go into making the care of children with disabilities less stressful on caregivers and helps to make the lives more comfortable and productive for those who are affected. And as a neurosurgeon, I feel honored to be able to take part in the care of these kids, but often it's at the very end after a whole long list of other caregivers have weighed in and given their opinions and helped out in many other important ways. I mentioned the questions in the chat box. Please feel free to go ahead there. And if you want to take a second to jot down Dr. Jones's office number or my phone number there to my office, we're always happy to give evaluations and to give our opinions, of course. And we often will see children together. So you get kind of a 2-for-1. So just a real brief definition of spasticity, because I think a lot of people kind of know it when they see it, but don't really know how to define it. Spasticity is really, in its sort of essence, a velocity-dependent increase in reflexes. So it's this idea when you move a limb really fast, you get kind of like this real severe catch. And spasticity can be due to any number of problems from upper motor neurons. Often it starts in the brain, but it can be due to spinal cord dysfunction as well. And again, I'm going to focus a lot of my talk on cerebral palsy because that's just a huge population of patients who have spasticity. But whether it's multiple sclerosis or spinal cord injury from trauma, there are lots of reasons why you might be finding yourself affected with this. And it's not alone. Spasticity is a big part of the picture for children with cerebral palsy. But you can see dystonia is also very important. And then there are lots of other little subtle areas that are way beyond the scope of today's talk. But it's important that you do see a neurologist and you do see your physiatrist so we can start parsing out the different movement disorders that are making up your overall disability, because spasticity is is the focus of the talk, but it's not the entire puzzle. And the different treatments will really depend very, very specifically on whether or not it's a pure spasticity or a mixed spasticity dystonia or something entirely different with respect to how these interventions may help you. So CP, cerebral palsy, the definition is a group of disorders of movement and posture causing activity limitation attributed to disturbances in the developing fetal or infant brain. And this can really affect sensation, cognition, communication, perception. A lot of these kids will have behavior and seizure disorders. And these are all super important when we're talking about a child with CP. But again, what we're talking about today is just simply the spasticity part. This is the motor disturbance that is caused by those upper motor neurons getting disturbed at a very, very early age, often by trauma, even in utero. And the MRI scans here show just a very, very subtle hints. Again, we're not going to get into too much anatomy here, but you see these little areas of white on these brain MRI scans, even these subtle little areas. This is called PVL. This is the classic finding of a child who may be a little bit premature. Maybe there was a rupture of membranes. Maybe there was some distress during delivery. For any one of these reasons, even infection, that can be enough to create some dysfunction in those neurons and create cerebral palsy. Sometimes it's evident very early in life. Sometimes it's not evident until many years later. It could be in very subtle or very severe form. So the entire spectrum is at play. And the entire spectrum is really important because some of the more mild cases do not even need to even sniff a neurosurgeon's office, whereas some of the more severe patients, we can help dramatically. And so it really depends where on that spectrum one falls. Here's another example of the MRI scan. Again, not terribly important for today's discussion, just to know that this is part of a bigger picture of cerebral palsy and movement disorders, and such that once you get to the point where spasticity is defined and diagnosed, and you're sure that that's sort of what you're dealing with, then you can really focus in on those treatments. And if there's anything else going on, getting down this line of spasticity treatment can be premature. So why is it important for us to help kids? Why do I, as a neurosurgeon, love this field? And why do I like taking care of kids with CP? Why is Dara devoting her life to it? Well, there are lots of things that we can do. So one is we can prevent orthopedic deformities. There are tons of things that are going on when there's excess tone. Hips dislocate, limbs get contracted, scoliosis develops. And it's across the entire neuromuscular skeleton that these things can be affected. So that's a huge part of what we do. But the things that are more tangible, how do we improve their activities of daily living? How do we make it easier for caregivers, parents to dress their children, to change their diapers, to actually help them go to the bathroom? Of course, everyone wants more mobility. So it's whether it's just being able to sit up more comfortably, or whether it's being able to go from a rolling walker to walking independently, or to being able to sit more comfortably in a wheelchair. Again, the goals of care depend on the severity of the CP. Then there are things that we may not think of. Preventing skin breakdown is incredibly important for patients who are sitting in a wheelchair all day long or aren't getting up, walking around. Pain is a huge part of this. Weight gain, sleep disturbance, psychomotor things like depression. These are all part of the panoply of things that we want to help by treating the spasticity. So it's a very simplistic thing to say, well, we're just treating the tone, but in reality, it's much, much more complicated than that. You can classify them in many ways. Hemiplegic, so that's basically one arm and leg. Quadriplegic, that's severe involvement of all limbs. Diplegic is a very common thing that we see when there's prematurity with PVL. That's both legs primarily. And then there's sort of these mixed ones that I was talking about earlier, right? Dyskinetic choreas, where there's a little bit of a mix of spasticity with some movement disorders as well. So setting the goals of the treatment, this is probably the most important slide. And this is the first thing that Dara and I talk about when we see patients together is, well, what are we trying to accomplish? Not every child is going to be able to get out of that wheelchair and walk like in the movies, but it may be just as meaningful that we can get them sitting up straight, or more comfortable in their chair, or more comfortable sleeping, or their parents might be better able to bathe them and dress them. And then there are some kids who are close to walking, and we think we can try and help them get to that functional walking stage. And so determining the goal of the treatment and understanding that sort of match between what the caregiver wants and the physician team is able to offer and feels is reasonable, is the first step in understanding that that is a likely goal to try and pursue and to hopefully achieve. So that's what we start all our evaluations off with. Again, these are some of the things that we talked about, again, just sort of in a different way, looking at the treatment goals: gait, mobility, positioning, hygiene, and cosmesis, all really important. To get into sort of how we evaluate the patients and how physicians talk amongst one another when we're describing kids with CP, a lot of rating scales have been developed. I'm going to hand off to Dr. Jones at this point to carry on describing a little bit how we evaluate these children, and then some of the medical managements. And then after she gets through that part of the talk, and she'll transition back to me, and I'll go through a couple of surgical options that we have for the more severe spasticity children. So I'm going to hand off right now to Dr. Jones.
Thanks so much, Jeff. Hi, everyone, and thank you so much for having me on today. As you mentioned, I'm a pediatric physiatrist, meaning I take care of children who have a congenital or later onset of some form of musculoskeletal or neuromuscular condition that requires ongoing rehabilitation. The majority of my practice is centered around cerebral palsy and the like. So to pick up where he left off, so any evaluation with physiatry is going to start with really a comprehensive physical examination, looking not only at the neurologic system, but also at the musculoskeletal system. So what is the available range of motion a child may have at all major joints, and looking at positioning of their spine. And then also, to what degree is there spasticity? And I won't get too much in the weeds with some of our assessment tools, but we have a couple of things that a couple of scales that we can use to really give accurate, objective measurements for muscle tone that helps us to communicate between other providers. One of the more useful ones is the Tardieu scale here at the bottom. It gives us more of an idea, not just of how severe is the spasticity, but it's an assessment of dynamic spasticity. How does this affect a person's ability to move, to do a particular thing? Most commonly, that's walking. And next slide. Another tool that we have is gait analysis. So I'm based at Weill Cornell and New York Presbyterian, but I also split my time equally at the Hospital for Special Surgery, where we have a motion analysis lab that is able to capture, this is kind of, I think of it as like our functional MRI in a lot of ways of getting a detailed picture at what's happening when someone walks. And that's looking at every single joint level in different planes, and comparing it to data for children who are typically developing. And it really gives us a good idea of how we can intervene, whether that's with bracing, therapy, surgery, tone management, or sometimes not intervene. What should we avoid in this particular child? So it's really, really invaluable piece of information that we're able to gather and use as part of a team as we're coming up with these plans. So this is an example of graphs. Stay with me, I hope I don't bore anyone, but just briefly, this is this child here in this picture demonstrates a typical kind of what we call a crouch gait. There's increased flexion at the hips and at the knees, and the ankles are in what we call dorsiflexion. They're kind of bent up. And so this is a common gait pattern that we see in cerebral palsy that's often due to the spasticity. And then here at the bottom are EMG curves that tell us which muscles are active and how long they're active at different points in the gait cycle. Muscles turn on and turn off at different points. And if a muscle is on for too long when it's not supposed to be, then that tells us this muscle is pathologic and may benefit from a particular type of intervention. Jeff touched on this already a little bit, but what I just want to emphasize here is this reflex arc that highlights what's happening and what the cause of spasticity is. The big emphasis in terms of how we kind of think about it from a physical perspective a lot of times is the sensory component that often is ignored, represented by this blue nerve here going from the muscle. The muscle is detecting some reason that can trigger a reflexive muscle contraction, that reflexive spasticity. And a lot of the physical treatments that we have are centered around trying to ameliorate that. And then all of our other targets are focused at kind of different levels, whether that's at the muscle level or whether it's at the actual motor nerve level that's causing the contraction. Next slide. So, with spasticity, it's important to remember that when we see a child with a particular deformity, it's easy to assume that it's just due to the hypertonia or the stiffness, but really there are multiple factors at play. There's both muscle weakness that is nearly just as important, even though a muscle may be tight and spastic, it's also very weak. There's also impaired selective motor control, which means it's defined as the reduced ability to really be able to activate a muscle across a particular joint for any particular demand. And it's a common neurologic sign. And then, of course, we also have to consider growth as a major factor. Next slide. So aside from potential for deformity, why else do we care about spasticity? And how are the goals different in children versus adults? Well, children aren't born with contractures or hip dislocations or spinal deformities. Those changes occur over time as the child grows if they're left untreated. What happens when a muscle is unable to relax, it leads to this mismatch between bone growth and muscle growth. And because the muscle is constantly tightened and contracted, the bone grows faster than the muscle, which can make the tightness even worse and lead to contractures. And so it's this sustained amount of pressure that distorts and effectively twists the bones into different directions that can lead to more musculoskeletal things that just tone management and neurosurgical procedures cannot necessarily address. So we try to intervene as soon as possible to really try to prevent this. Next slide. So the treatment options for spasticity are variable. I think about them from being generalized, something that's going to affect the entire system, or many muscle groups at a time, or focal. Are we looking at a specific joint that we want to improve, whether it's just getting a child off their tiptoes or helping with hand movement? And then we can also think about it from how reversible it is to how permanent it is. In this generalized and reversible category, that includes oral medications, intrathecal baclofen, which Jeff will touch on, as well as deep brain stimulation. Reversible things, but that are more focal, include serial casting, which I'll mention in a minute, and chemodenervation, which includes Botox injections and alcohol neurolysis, which I will also discuss later. The generalized treatments that are more permanent include selective dorsal rhizotomies, also forthcoming, and those that are more focal, meaning we're looking at a particular joint or one or two joints, would be orthopedic surgery. So when we talk about spasticity being part of a motor disorder, it's also important to remember those other components that I mentioned. It's their tone, it's their strength, the anatomic length, tension relationship of the muscle to the tendon, and selective motor control. And therapies ideally address all four of these, but depending on the child's needs, we may prioritize one or two over the others at any given time. So there aren't any true therapy interventions that have been proven to be superior, but rather a combination of things. So stretching, strengthening, functional training, and serial casting. And serial casting consists of applying a series of casts, stretching casts over generally 4 to 6 weeks at a time. Where, say, for example, the ankle, which is the most common joint that we cast, the ankle is gradually placed into more and more dorsiflexion until ultimately we're able to improve that range of motion and reduce the equinus positioning of the foot. Bracing and orthotics, like an ankle foot orthosis, can also be helpful with relieving spasticity. Next slide. So now moving on to the medications, which falls into that systemic, that generalized and reversible treatment. There are a whole host of medications in our tool belt that we can use. Each have their pros and cons, and we're trying to work at different levels of the nervous system as well as the muscle to try to affect improvement. The most common medication that is generally prescribed is baclofen. It works by kind of calming down that hyperreflexic arc in the brain, working on certain chemicals. The most common side effect, as it goes for any of these medications, because they're all trying to reduce a hyperactive state, so to speak, is that there's often some degree of sedation or increased sleepiness, impaired cognition and memory. One thing that I try to encourage my families or educate them about is that generally these medications do require some degree of tolerance. So, the side effects are usually the most common in the early first 1 to 2 weeks of taking it, but then gradually reduce as the individual acclimates to the treatment. But they do, because there is this degree of having to acclimate to it, there is also the risk of withdrawal if the medication is suddenly stopped. So it's something that you have to gradually wean down. There's one medication that comes with less risk of sleepiness and fatigue, and that's dantrolene, because it's working directly at the level of the muscle. It does have side effects. It can cause some sleepiness, but not as much to the extent of baclofen or diazepam. But we use this one with a lot more caution because there's a risk of liver injury. So while the systemic medications can be helpful, they definitely come with a lot of side effects. So we try to shoot for the more focal treatments. So next, I'll talk about botulinum neurotoxin and the different types and how it works. So botulinum toxin, everyone is familiar, or probably more familiar with the most common preparation, and that's Botox, botulinum toxin A on the far left. But there are actually 4 different preparations that are commercially available. And they all work the same way by interrupting the connection between the nerve and the muscle. And it just temporarily decreases that signal, generally for about 3 to 4 months, so that a muscle is a little bit more relaxed and we're able to achieve whatever our goals are. All of these have, the 3 of these, Botox, Xeomin, and Dysport have approval in pediatric patients. What your provider chooses is mostly dependent upon experience and comfort level, as well as with the type of muscles that we want to inject. Next slide. So Botox lasts for it has an onset, of about 3 to 7 days, and it has its best effect at about 4 to 6 weeks, and then it lasts generally for about 3 to 4 months. We try to avoid injecting more than 4 times a year. Adverse effects can include some temporary muscle weakness and fever, but that usually resolves within the first week. Next slide. And this is I'm going to show a video of a patient of mine. This is her walking before Botox. As you can see, she's already got a bit of a deformity at that left ankle up on her toes. That was pretty rigid. And then here, this is about 4 weeks after Botox and serial casting. Now she's walking a little bit faster and is able to get her foot all the way flat onto the ground. Often Botox is used in conjunction with serial casting to really maximize the effects and the amount of stretch. And then I always have a strong recommendation for following it up with physical therapy. Next slide. So next we'll talk a little bit about alcohol neurolysis. So alcohol and phenol, or ethanol, both work in similar ways. The way they work is by temporarily destroying or kind of dehydrating, so to speak, the nerve that's supplying a particular muscle, thus decreasing that muscle spasticity. Due to weight restrictions, Botox dosing is often limited based on the child's size. So phenol can really be a nice supplement to be able to combine the spasticity treatment all in one session. Nerve blocks using alcohol is generally reserved for nerves that are more easily able to be identified, such as the nerves that go to the hip, the inner thigh muscles, or the hip adductors. It's important to know that these treatments do help, but they don't always alter the natural history of subluxation in cerebral palsy. So it's important that we also still continue to monitor their musculoskeletal growth as well. Some of the risks of, some of the risks of alcohol neurolysis can include pain and dysesthesias and skin sloughing. And that about summarizes some of the medical interventions, and now I will turn it over to Jeff.
That was wonderful, Dara. Thank you. Sorry about that quick trigger finger there. I think it's important to emphasize what Dr. Jones said there, that these are temporary and they're synergistic. I mean, these are not sort of you pick one and that's it. We will often think about the intervention as part of the overall treatment scheme with respect to their age and their size, and say, well, this is what we're going to do for the first year, and then we're going to reassess and evaluate. Maybe you'll be a candidate for this treatment when you're a little bit older. Maybe we'll reevaluate depending on how you respond to this treatment. And so there's a lot of back and forth and a lot of interaction between the providers on this team. Intrathecal baclofen is a natural takeoff from the oral baclofen, which was the first medication that Dr. Jones was talking about. And the reason why this was developed was essentially to counteract the significant side effects that some kids were having with the higher doses. It's extremely efficacious. However, the side effects were making it intolerable. And so the idea of giving the medication directly where it's needed, i.e. directly to those nerves in the spinal cord where those receptors are, was something that was sort of thought about and approached probably 30 or so years ago now, and has been incredibly successful. And so the idea of giving much less medication, but in a more focused way to those nerves has been sort of the tenet of what baclofen pump or intrathecal baclofen is based upon. And this is what the pump looks like. So it's a small hockey puck sized pump that contains within it a reservoir and a battery, and it attaches to a catheter that you can see here on this diagram. The catheter is threaded through a very specific route into the spinal canal, and then threaded up into the spine in the fluid around the spinal cord. And so the medication is then delivered into the cerebrospinal fluid and diffuses throughout the fluid and affects all the nerves. So it avoids the systemic toxicity throughout the entire body and focuses directly on the nerves that require it. It's wonderful in the sense that it is reversible. That's something that we always talk about. Can this be reversed or not? You could always take the pump out if you don't like it. It allows extreme precision in terms of the delivery of the medication. You can control the rate, the mode, and the pattern. If you want a high dose at night to help you with your sleeping, or you want to time your dosing around your meals or your activities, you can do that. And it has a lot of feedback through a wireless program or a system, which is even newer than the one that's shown on this 10-year-old slide here. So that's what the pump looks like. Putting the pump in is sometimes a tough decision because it's really good for patients with severe spasticity, but there are some limitations. The first is that we typically have to be at 3 or 4 years old at least. I'll talk about that on the next slide. We've tried to lower the age criteria as much as we can safely, and I'll explain why they have to be a certain size. But we try to assess them with a trial dose. This is something that some children go through, not all. This is basically a single test dose, so the family and the caregivers can assess the response to that test of baclofen intra CSF. And once we know that the response has been adequate, even if it's too high or too low, we know that we can modulate that when the pump is put in. The downside to these pumps is, a big commitment. It's basically an implantable device that you have to maintain forever. You have to refill it every 6 months at a minimum. And it is prone to complications like any other device being implanted in the body, namely infection. It's a foreign body, and so we have to really be vigilant about that. I partnered with a plastic surgeon at Cornell a number of years ago because we were trying to get these pumps into really small children who were cachectic and didn't have a lot of soft tissue. And in older patients and in adults who have enough abdominal tissue where the pump is placed, it's quite easy to put the pump and hide it cosmetically. But in very, very small children are those, and many children with CP who have very, very high metabolic rates and are very, very cachectic and muscular, it can be hard. And so we devised a pocket system underneath one muscle and between two muscles to allow it to heal and to cushion it appropriately. And we've had wonderful success getting these pumps into young children and allowing them to benefit from the positive side of baclofen intrathecally without some of those negative side effects. Again, this is kind of what it looks like here. It's a very short procedure. It takes about an hour in the operating room, and kids will stay either 1, 2, or 3 days, just depending upon how many times you want to modulate and adjust their pump before they go home, because there's going to be a lot of adjustment and modulation as an outpatient. Sometimes it can take several months working with Dr. Jones to figure out exactly the right dosing and schedule to get them optimized. And again, this is something that can be done as an outpatient and can be modulated over time. And as different parts of the cerebral palsy develop or are treated with focal treatments, the reliance on the baclofen pump may increase or decrease over time, and that can be easily adjustable. And they last about 8 years in general with respect to the battery life and how often that pump might need to be replaced. The complications, I already indicated a little bit that this is just a device and it's prone to all those things. So you can get an infection or have a pump get blocked or clogged or something like that. That's not that frequent, but it is a reasonable thing to consider. Overdose and withdrawal, when you're giving medication into the CSF, you have to think very carefully about what happens if it runs out, and there are alarms and beeps and things that the pump will give to the caregivers and the families to alert them to this. And there's usually lots of warning and feedback, but it's something to consider. And if you get too loose, you can have problems with posture and tone, and even can lead to difficulties with scoliosis. And so everything that we talk about always has a pro and a con, and this is part of why this is a great field, because there's lots of options, but lots of complicated decisions to be made as well. The other surgical technique that we use to deal with spasticity is called the selective dorsal rhizotomy, and it's completely different. It's different because it's an actual surgical disruption of that reflex arc that Dr. Jones was describing. And so it actually involves a permanent sectioning of some of the nerves that are abnormally firing and causing that increased tone. So as opposed to a baclofen pump, which is reversible and takes months to titrate, a rhizotomy is much more definitive, but it works right away and is not reversible. When you cut that nerve, that's a decision you make. It's not as scary as it sounds. These are nerves that are highly dysfunctional and are only contributing to the negative side effects. But obviously the idea of cutting a nerve is something sometimes difficult for families to wrap their head around. Those gait analysis labs and some of those EMG pictures that Dr. Jones was showing you are incredibly important, because we have a really good idea and plan going into surgery which of those nerves are going to be dysfunctional. And then during surgery, we actually monitor them. This is a much longer surgery, and we monitor each of those nerves. And after monitoring all the nerves that go to the legs, we'll make a decision on which ones are the most abnormal and cut only those. And then this is followed up with a good deal of physical therapy, often inpatient, for a few weeks at a children's specialized physiatry facility where they can work very, very diligently to get those muscles strong again and get you walking more naturally. A lot of kids with CP are actually using that tone to keep themselves standing, or to giving themselves that crouch gait that Dr. Jones showed as well. That's not really strength. There's a lot of underlying strength behind that, but that's actually tone keeping them up. So you eliminate that tone and kids will feel weak, but you really then give them the opportunity to build up that natural tone through physical therapy. So it's incredibly rewarding. Takes a little bit more time, but it's definitive, and you don't have the side effects of having that pump inside your body forever. So there's definitely some pros and cons there. Definitely better for sort of those young kids who are on the border of independent ambulation. So kids who are in a rolling walker with that crouch gait, We're just looking to increase that range of motion a little bit, try to get their foot flat, get those hips opened up a little bit. They're typically kids in that 4 to 6 range, although indications for this are dramatically expanding as more and more providers become familiar with it, and we try to push the envelope a little bit in how to help kids with spasticity. This is kind of what it looks like. Again, a little bit, probably too much information, but it involves opening up the spinal canal and looking at the roots. These are all the roots right here. We can see exactly where they're going, and then we actually put the bone back on at the end. But at each individual nerve level, this is a zoomed in picture, you can see that there's both a ventral root and a dorsal root. So one is the motor root that controls the strength. One is the sensory root that takes the information in from the muscle. Again, that's the arc that Dr. Jones was describing. We can look at them. You can tell them apart very easily. We monitor them to tell which is which. And then we take out these little rootlets from the dorsal portion, the sensory portion of the root, and we snip them when they're abnormal. And that's all it is. It's quite straightforward. It's meticulous and slow, and it's incredibly gratifying when the surgery is over because the results are immediate. And we talked a little bit about that intensive PT following up there and strengthening afterwards. I did want people to have an opportunity to look at this video. If you just Google Mighty Micah, it's a wonderful video. I didn't think we had time for it here. It's actually a child out in California who goes through this process of selective dorsal rhizotomy, in the preoperative evaluation, the surgery, and then the post-op follow-up, to give you an idea of how transformative this type of surgery can be for the right candidates. So if you have an opportunity or interested in learning more about it, obviously you can reach out to us, but you can also take a look at this and get a sort of an unfiltered view of what that looks like. The overriding philosophy and why I wanted Dr. Jones to share this seminar with me is that this is really a team approach, and it's just an enormous number of people who impact children with cerebral palsy and can improve their lives. And so we're part of a very, very big team, and we're grateful that so many people are interested in taking care of this population, because I think they're just so deserving and so wonderful to care for. It's one of my favorite parts of my job, honestly. So this is just me and Dr. Jones, but there are many, many more people who are involved in this. I think we try to cover the major topics here. Obviously, we couldn't touch on everything, and there's a lot of nuance. We're definitely available if you want to stay on and ask some questions in the chat box. If you have any individual questions that you want to point towards Dr. Jones or myself, please feel free to reach out to our offices. We're happy to talk. And if there's anything that I went through too quickly, or you wanted to review again, this will always be available later on YouTube and on our website through our department, so you can look back on it later. So if that's a wrap on the talk, should I open it up maybe to see if there are any questions? I have been following the chat box. I don't know if there's anything out there that we'd like to address together. Have you seen anything out there, Dr. Jones?
Amanda Wigan had a question that I answered in the chat box for everyone to see, but it was a good question. She brought up specifically about whether or not having one leg shorter than the other can have any issues with walking or muscle spasticity or things like that. I wouldn't say what it makes me think about is really there's an interplay between the muscle and the nerves and those effects on the bones. Generally, having one leg shorter than the other doesn't necessarily affect spasticity, but rather is an effect from spasticity in some ways. We often see that with any sort of underlying neurologic condition in a growing child, if one side is a little bit weaker than the other, that side isn't getting the same opportunities for weight bearing and for strengthening, and so that bone does not grow quite as much as the typically developing size. And that's usually like someone who has one-sided weakness, like a hemiparesis, for example. Does that make sense? I hope that answers your question.
That was great, yeah. There's also a good question about, well, actually, Roseanne asked a question about incidence of CP with better maternity birth care. And I don't know if that was a setup or not, but I think that that's probably not actually the case. I think part of better healthcare and better, sort of neonatal care means that younger and younger children are actually surviving when they previously wouldn't have. And so it's actually probably the counter argument that we now have 24 and 28 and 32-week-old children who probably wouldn't have survived even 10 or 15 years ago, who now are, and so are probably being born with some degree of neonatal trauma or injury. And so I think that's probably not going to be something that we're going to see a huge improvement on, even as technology improves. The unintended side effects of that are actually probably going to keep the population of CP children relatively high. The most important question here, someone named Danthan asked, which is I think probably the crux of the entire talk, which is how do you determine which is the best therapy for any individual person, particularly rhizotomy? And I think that's the whole kind of magic of having a neurosurgeon, a physiatrist, a neurologist, orthopedic surgeon all working together with a caregiver. You have to establish what the goals of the care are, take into account the age, the etiology, what treatments they've had, and then figure it out. And we're quite creative and we're quite adaptive. And I think that there are increasing indications on both sides of the spectrum. We've recently been talking about dorsal rhizotomy for children who primarily had been left out of the conversation for many, many years because they were felt to be too disabled to benefit from it. And in fact, it may really be, again, the opposite. And that is, well, if maybe you're not going to be able to walk, or your child may not be ambulatory ever, but if we can permanently create a more comfortable existence with decreased tone, maybe it's better to do a real aggressive rhizotomy than to put a baclofen pump in. And that's sort of flipped from the way we were taught 15 or 20 years ago, that those children would not be candidates for rhizotomy. And so I think, each team might have a slightly different perspective, but thinking about the goals of care and thinking about it in a creative sense is going to give you the opportunity to really think about this as a long-term care solution for your child or your loved one. So great question.
And just to kind of add on to that, I think that the operative word in selective dorsal rhizotomy is selective. So we're very selective. Jeff is not just selective also with the nerves that he's choosing to cut, but also in which patients are good candidates. And that's the whole reason for such a detailed analysis, seeing both Jeff, myself, an orthopedic surgeon, physical therapy, and that way we can all kind of have a consensus in terms of looking at just different variables in terms of why a child may or may not be a candidate.
Well, I think that, this has been kind of a nice overview for everyone. We're always available to answer questions. I think if you ever want to give us a shout out through email or through our office phone numbers, we're more than happy to set up a consultation or answer a quick question for you. So on behalf of Dr. Jones and the Weill Cornell Medicine Neurological Surgery team and house calls and the wonderful new team of Columbia Cornell Pediatric Neurosurgery, thank you so much for joining us. And stay tuned. If you've registered for this, I'm sure you'll get announcements of our next seminar series. We have them every month. And Dr. Feldstein and Dr. Hoffman will be the next two up. So look forward to those and enjoy the rest of your beautiful afternoon. So thanks for joining us.
Bye, everyone.